Hey everybody, let's talk a little bit more about tibial nerve entrapment. So that's going to include our tarsal tunnel syndrome, sort of in this area, but also let's not forget our Baxter's nerve entrapments as well. Initially, positioning of the patient, I'll typically just have them, sitting in my chair, and I'll just rotate the leg out a little bit, just so that I can get a bit of a better feel and look at sort of where I'll be treating. Basically, the approach really is dependent on the level of entrapment, and what we're wanting to remember is that we want to go, 2 or 3 levels above where that entrapment is. So if it's, maybe post-traumatic and it's a little bit higher on our calf, then, and remembering the tibial nerve's quite deep, we might want to start up a little bit higher in that sort of sense, and therefore we might be going up to some of these higher levels. But, if it's really in that tarsal tunnel area and, I've got a few of the nerves that are relatively in the correct spot, but remembering that this tibial nerve does dive very deep, we do want to just be making sure that we're on the right track here. So typically what I find is really just posterior to that medial malleolus, as we're bifurcating into the calcaneal nerve, and then as we're coming further and bifurcating into our medial and lateral plantar nerves, we're going to have a few. And then maybe just a little bit further down as we're getting past, our areas of, that tarsal tunnel, to make sure, and that's typically at the inferior level of the medial malleolus, where the retinaculum comes over, and that's going to be sort of, one of these more distal aspects, and sometimes it can be a little bit more distal to where you'd think that tibial nerve is, because it's one of those superficial feeding areas of where that pain can typically refer. Now, that's going to pretty well cover off tarsal tunnel, but then as we're coming to the Baxter's nerve, we've got to remember that's of that lateral plantar calcaneal nerve. It's going to be really deep, and what we're talking about is this quite lower one, and we do know that there's a bit of an instep there, and we do want to push that fluid in a little bit deeper past that abductor hallucis muscle belly a little bit at times, as well as putting it in that superficial area, so that we can really make sure we're wrapping that nerve in that 5% dextrose. Now, that's covering off locally, and if you did all of these spots, you're going to be in a really good position. But remember, start walking up that leg, start feeling, okay, yep, maybe I've got some pain here, I've got it maybe around this area, and then keep coming up. Now, you might not find that all of these spots are painful, and that's great. For ones that you do find, yeah, hit those definitely, and you don't necessarily need to go all the way up to that medial, condyle of the knee. Just really take a bit of an idea of, okay, what's happening here? Where am I finding these? In saying that, if patients aren't exhibiting any pain, then you can use this type of a model as a guide and see how people will respond to that. People will typically have an immediate response to this type of injection. They'll say, oh yeah, it feels a bit lighter, it's a bit freer, my ankle's moving a bit more. They shouldn't have that pain, and typically we'll see that 50 to 90% decrease in pain immediately, but sometimes it can be a little bit delayed and take overnight to take effect as well. Definitely, when we start talking patient tolerance, our patients don't like these ones in the Baxter's nerve, don't like that deep tarsal tunnel sort of injection in here. Sometimes around sort of as we're getting into those calcaneal nerves as well, it can be a little bit more tender, and so really just being aware of that. For my patients, I definitely give them a stirrup with some Hyperfix just to make sure that patients are comfortable, and we'll typically undertake some high-powered laser therapy, PBMT, just before they come through for these prolotherapy sessions. Don't forget your orthoses, your strengthening, your intrinsics, as well as some heel raisers as appropriate. Do consider whether a corticosteroid injection may be more appropriate as well, particularly if there's something like a ganglion causing that entrapment. Very good idea to image these type of patients beforehand, but at the same time, if you're staying superficial, it's quite a safe option to do. Do be aware of blood flow and vascularity, particularly as that can cause some of our tarsal tunnel syndromes, and you're wanting to really try to avoid any of the veins or the vessels in that area. Of course, as always, we're injecting as we're entering the skin to make sure that there's less a chance of occurrence of too much bleeding or nerve injury as well. But, that's given you a little bit more information on that tibial nerve entrapment, whether that's from the tarsal tunnel syndrome or our Baxter's nerve entrapment there as well. Cheers.